Guys, welcome to another episode of the House of Health podcast. Today, we are talking about a very pressing subject, something that has been in the news. Everyone's been talking about that. The in thing, which are the weight loss injections. We have just the right person as our guest today, and it is Dr. Sobia Arshad, who's a consultant endocrinologist, a hormone specialist who has a thriving private practice in London, and has seen many patients relating to weight loss and many other endocrinological conditions. How are you?
I'm very good, and thanks for having me.
No, thank you for coming. So let's jump right into it. We have done previous videos around how the GLP-1 medications work, but we'll be talking about the more juicy stuff, as you call it. Okay. So let's start with your experience, because I know you have been prescribing these medications in your clinic. What has your experience been around prescribing it, the effects on different patients, and just take us through your practice?
Thank you very much. My experience prescribing this and listening to the feedback from patients is extremely positive, extremely positive. And I want to say that because I prescribe it in NHS and privately, the experience is very different on both sides. For some reason, when they get it for free on NHS, they don't tend to lose that much weight. I partly because they don't get the right amount of counseling, maybe the support, or maybe they don't have that motivation, or it's just like a freebie. But when they pay money and come to an endocrinologist and in the private sector, they tend to lose a lot of weight. So I have patients ranging from who have lost 7-8 stones. The drug they claim that you can lose anywhere between 10 to 20%. So 10 being Ozempic, 20 being Mounjaro. But in real practice, patients have lost up to 30%, which is a very significant weight loss. And obviously, with their weight loss, the positive body image comes and the confidence, and they're very happy, and they can reverse their diabetes and cholesterol and hypertension. So very, very happy people.
Absolutely. Anita, coming on to you. You've obviously been running a weight loss clinic at House of Health, a very successful one, alongside Dr. Arshad. So, do you want to tell us what your experience has been around the weight loss medications and what do you think about them?
I think it is a great advancement in medical science. I genuinely agree with Dr. Arshad's comments that it's completely transformed the lives of our patients. We run fertility clinics at the House of Health as well, where we see many young girls who are in their 20s but morbidly obese, struggling with fertility for years on end. However, they don't know what to do. They don't qualify for IVF on the NHS. They don't know how to lose their weight because, unfortunately, in the 10 minutes that we're given within the NHS, the GP can only give you a very brief advice, refer you right, left, center. There are not very many places left in the Midlands where you can refer these patients. And they're just left in limbo. So we see some of these patients come through the door, and the way we look at them is that we advise them to lose weight first. And it's really magical because their insulin resistance is reversed, like Dr. Arshad said, their diabetes, their hypercholesterolemia, their hypertension, and they genuinely feel happy. I mean, the comments they get from family and friend, it's so good for their mental health as well. So I think it's been quite positive.
The reason I ask you this question is, we are sitting in Ultimate Fitness, and in general, the fitness community, whether it's bodybuilders, whether it's personal trainers, they look at these weight loss injections and still frown when they look at these and discuss these. They think that it's a shortcut. They think that this should not be prescribed. It's for lazy people. Whereas, I have to say, I'm a convert. I used to think like that. But when I see these patients who've never entered a gym, who've never done any kind of physical activity, they just cannot do it. And telling them the same advice again and again to go to the gym, to start losing weight, it's not going to work. It hasn't worked. Why is 1/3 of the world population obese? This is the reason. And these medications help them. They give them that kickstart. Yeah. So that takes me on to my next question is how much weight loss is healthy? And then we find that some people say, well, I've been on this medication and I haven't really lost much weight. What is the reason for that?
So we have to see every person individually. It's not one size that fits all. Because of, weight loss drugs historically always been abused. Whenever you will put a weight loss on that, people will try to get it left, right, and center, and they will use it the way they want to use it. My job as an endocrinologist is to see health goals and not aesthetics. And we need to tell our patients that what their goal is as well. Now, if your starting BMI is 27, you're not going to lose a lot of weight. These drugs are most effective in people who have very high BMI, at least above 35. If your BMI is above 35, then these drugs, they're claiming that you can lose 10 or 20% in a year, and they do. And some people a bit more, up to 30%. But if your starting BMI is not there, where are you going to lose weight from? So you have to be realistic as well. Health-wise, we do not want people to lose more than 25 to 30%, because after that, it's just like having a surgery. We know that we have a lot of experience from surgery, from gastric sleeve, from gastric bypass, that these patients do develop deficiencies and they need to be on vitamins and for lifelong. So if you lose that much weight with the injection, you are going to develop this deficiency. And the most common is like hair loss, or I'm feeling very tired and I can't do this. Of course, it's all is going to come. So have a realistic goal, having health goal more than aesthetics, and then trying to achieve that.
Yeah, and taking it from here, Dr. Sobia, muscle mass.
Muscle mass,
10 to 20% of muscle mass. So extremely important that you are on that 1 gram of protein per kilogram per 24 hours. I mean, Dr. Sitwa and I, we prescribe alongside Dr. Sobia Arshad, the weight loss injections. And this is something we hammer into each and every patient of ours. And weight training, strength training is so important. Dr. Sobia, I wanted to ask you, you mentioned sort of bariatric surgery. Where do you see the future of bariatric surgery now that we have GLP-1s?
So the debates are already started on will NHS be supporting these surgeries anymore or not, especially the gastric sleeve. So the two surgeries that NHS supports are gastric sleeve and gastric bypass. Gastric bypass have a potential to lose more than 30 up to 50%, gastric sleeve 30%. But now, because the drugs are able to lose 30%, there's a debate of why should we even offer that. So the future is that maybe it will be reserved for people who are not able to lose weight on these injections, or if their goal is to lose more than 30%.
Okay.
I think that makes sense. Why would you want to go through an operation when you have an easier way of administering the drug, which will do the same job, right?
It's just because I see a large variety of people. I can still see the role of surgery, because, as I said, it's not something that fits everyone. But yes, the majority would not go through it. So the numbers will reduce dramatically.
Now that you're a gastroenterologist and you're a hepatologist, you're a consultant here in one of the renowned hospitals in Birmingham. And when we talk about GLP-1s, we worry about loads of side effects. So the first questions patients do ask is sort of, what about pancreatitis? What about the risk of death? Why do people get pancreatitis or gallstones or gallbladder problems when they're on these medications?
The most common side effects from weight loss medications, the GLP-1, they are peptides, right? So they act on your gastrointestinal tract, reduce gastric emptying, but then they also have a cascade of other effects on different pathways. And one of them is obviously gallstones. Now has been in the news. There's more clinical evidence. In fact, randomized controlled trials and meta-analysis, which is considered the highest form of evidence, looking at all the clinical trials, over 1,000 people, when they looked at the risk of gallbladder disease, it was quoted to be 37%. So that is your increased risk compared to somebody who's not on these medications. So there is a theoretical risk. Now, the question arises, why do they develop? Now, we know that GLP-1 analogs can reduce gastric emptying, but they also have a direct effect on gallbladder motility. So they not only cause stasis of your bile flowing through your biliary duct systems, which increases your propensity of developing gallbladder stones. So that's number one. The other mechanism in which they act is they cause supersaturation of your bile that mix with cholesterol. So most of your gallstones are cholesterol bile duct stones, and that increases your chances. Now, when these gallstones develop, the chances of pancreatitis become higher, because one of the main causes of pancreatitis is gallbladder disease, or gallbladder stones. There are also clinical studies looking at these medications' direct effect on the pancreas and its tissue, whether it increases that. It certainly increases your lipase and amylase production. So there are direct effect of these medications. Now, certain people will have more chances of developing pancreatitis on these medications. People who are obese, people who've previously have been smoking. So these are risk factors that increase the chance. And Dr. Arshad may allude to this, is that if they're using increased doses, like higher doses, they're reducing their weight very quickly. All of these are known risk factors in clinical studies. So yes, there is a risk. And this is why you should come to medical professionals who can monitor you, who can look at your blood tests. You see them regularly. You tell them if you're developing gallbladder pain, abdominal pain, and monitoring is important.
Very important. And the additional risk of people who are type 1 diabetics or insulin diabetics on insulin, they already have very tired pancreas, or alcoholics or who consume a lot of carbs, or their starting cholesterol is very high. I just want to add, it's actually not that high. The risk of pancreatitis is not as high as with GLP-1. It's still a rare side effect.
Yeah.
And they are still reporting that to see the exact numbers. To be honest, none of my patients had pancreatitis, and I've been prescribing it for 5 years now almost, including NHS and now in private. But you have to choose your patients carefully. And we also should not forget that the biggest risk factor for anything, including pancreatitis, is obesity.
Yes.
Absolutely.
So we can't say that we are increasing the risk. We might be managing the risk. And if we don't treat that, they are already on the risk of developing much bigger problems. So you have to balance that with the risk and benefit. And of course, you can minimize it by telling them not to drink alcohol, manage their cholesterol, reduce their cholesterol, check ultrasound, make sure they don't have stones already. And there are lots of morbidly obese patients where we sometimes do an elective cholecystectomy, remove their gallbladder, and then give them GLP-1.
I mean, Anita, you can clearly tell us about one patient who who was on weight loss medications under House of Health and then came to you with abdominal pain. Do you want to tell a bit about that patient?
Yeah, so we had a patient who was not under the House of Health, but they were ordering their GLP-1s online from a pharmacy. But they came to the House of Health because they knew that we also run a weight loss clinic. And they came to the House of Health because they were feeling quite uncomfortable. They had gastric pain. They didn't know that they looked jaundiced, but they clearly did. They just thought that, they had some gastroenteritis or something like that, came to us for some advice. And when we saw them, it was clearly a red flag. So we offered them urgent blood testing, urgent ultrasound scan, same day. And they were then admitted into hospital because the bloods were so deranged. They had jaundice.
And what was that? They had additional risk factors?
They were morbidly obese. They were morbidly obese and their cholesterol was high.
Cholesterol.
Yes. And but the thing is, my worry here was that, when you order from an online pharmacy, you don't really have this human interaction.
They don't understand the side effects, the risk factors, what they need to be monitored. So I always tell my patients that there is a rare side effect. And if you develop abdominal pain like that, you don't just say, you come and speak and we will check. And if you develop pancreatitis, that means we can't continue the drug. We need to stop it. We need to sort it out. But as I said, in morbidly obese patients, they already have such high risk of developing pancreatitis. That patient could have had pancreatitis without GLP-1 as well. So if you want to then reduce their risk, you may want to offer them cholecystectomy electively and then give them injections.
Now, this brings me on to the pressing hot topic right now, the price hike. We were all blown away by which was quite substantial. And I know these medications have never been cheap, right? And now people are seeing the effects. Now, I was telling, someone earlier on that these are people who have never been able to lose weight, some of them. They now have lost a lot of weight. Their self-esteem is back. They are confident. They can think better because we know that obesity can also affect your cognition. They're now getting compliments from their partners, family, friends. Everyone's saying, "What are you doing? This is magic. How have you lost so much weight?" So, people have now been able to do what they've never been able to do in their entire life. So, what do you think is going to happen? Because obviously the price hike is quite a lot, and we still have to see the ripple effect of that. So, what do you think in your practice is going to happen? Are people stop going? Are people going to stop
People
using
are
it?
never going to stop because, as I said, historically, people have always tried to get their hands on magic pills who can make them lose weight. That's always been the case. So there will be people who will be buying it. Uh, Two things will happen, I think. One will that NHS might have to reduce the threshold, and they are already doing that. They, lots of people will qualify through NHS. Those who will not qualify through NHS, I think they will find a way to get whatever injections they can afford. And there are a number of injections. The fear that I have is that they will be tempted to get it from black market for the drugs which are not licensed and trying to cut the consultation cost. And they will say, oh, my friend can give me from a gym
Yeah.
or, so there will be lots of that stuff will happen, which I wish and hope that doesn't happen because it's going to create more problems and bad press to the very good drug. But I think people will not stop buying
Do
it.
you think there will be people moving back to the medications that have been there historically? So things like Ozempic
Yes.
and
Yes,
yeah.
and Ozempic was amazing, and Ozempic is not any like a bad drug, especially if you don't have a very big goal. If you want to lose 10-15%, Ozempic does the job very nicely. Wegovy does the job very nicely. Mounjaro, I think, should be for reserved for people who actually have a very bigger goal. And what some of the patients have done, and they've told me that because they've achieved their target and now they want to go to maintenance dose, so they're going to use those as a maintenance ones.
Wow. And this is the issue. UK, as we know, is a wild, wild west of, there are no regulations. People are buying it off the internet. I had somebody tell me yesterday he had an IV NAD drip in one of his friend's house. And then when he went home, his heart rate was 150 and he had a temperature of 40 for the next 24 hours. So he was having a reaction and nobody had counseled it. So he could have died from it. So this is really dangerous when
It's
people buy it off the
dangerous. It's
internet.
dangerous, and they don't get the right results as well because they don't get the right support. Because when I give injections to people, I tell them that this is going to make your journey easier, but it's not going to do the work for you. 90% of that is still in our brain. You need to change the vocabulary, the mindset. You need to have a right motivation. You need to understand how the drug works. You need to work along with it to get the results. If you don't do any of that and rely on injection, you're not going to lose anywhere.
Anita, it takes me on to my next question around the cosmetic effects of rapid weight loss. We know that people lose muscle, as you earlier said in the podcast. Do you want to tell us a bit why this happens? Why do people develop Wegovy bum or Ozempic faces or skeleton
what?
look?
Wegovy what?
Wegovy bum.
Wegovy bum.
Yeah, I just made that up.
Oh my God, I haven't heard of that.
Well, as we know, there's a lot of muscle mass loss as well. So we've got to appreciate that. With fat loss, we have muscle mass loss, and that can give you that gaunt look where you look extremely tired, especially around your eyes, under your eyes. With your cheeks sort of going in. And we know of that. And I think since people have gone on GLP-1s, when it comes to aesthetic medicine, it's booming because there are now these rejuvenation packages which actually work around the face that you get after, injecting Ozempic or Mounjaro. And they target those areas where you're losing the muscle, the fat, and it gives you a more rounder, more rejuvenated look. However, I think, as all of us have been saying before, one of the most important things is that we lose this weight slowly, gradually. We have the right diet, the right nutritional advice. We don't buy it off a friend in a gym. We don't buy it off the internet in a while. It needs to come from an authentic place. The pharmacy needs to be authentic. It needs to be registered, regulated. The clinic needs to be authentic. All of us doctors are regulated in the UK, which is amazing because this means that before we prescribe something, we're putting our license at risk. So it's always safer to go to a healthcare professional who is regulated and would think twice before giving you something.
Absolutely. That's well said. Retatrutide, a new peptide that's making the rounds. There's news. I saw on Ultimate Fitness stories around people asking about it. I know it's far from being approved as an official licensed medication, but as you know, as we've discussed, you can buy anything off the internet. So people are using this peptide. So what does it do? And, where are we in terms of where is it at the moment? And how far do you think that's going to in terms of getting approved as a weight loss medication?
So it's very promising drug, very, very promising drug. And I was really shocked to receive a call from a GP last week saying that, oh, this patient is on this drug. And I was like, but that's not out. That's not available. Where? I said, oh, they got it from gym somewhere. And then I started doing my research and I found out that people are sourcing it from Amazon and from, I don't know, I just said Amazon, from online sources. And these are not the end product. These are the drugs which are still in trial, and they're only been used on animals. They've never been used on human beings. And it's in a phase 3 trial. It's going to come out next year, or end of next year, 2026, hopefully. It has 3 peptides. So just like Ozempic had GLP-1, Mounjaro had GLP-1 plus GIP, this one also have glucagon receptor blocker. So it, of course, it's going to work more effectively. It just sounds too good to be true because it's promising 25% weight loss, which is a very significant amount of weight loss. So I think the question will now is that how will they get more side effects? Like, will they lose a lot of muscle? Will they get very tired and fatigued? So I tell my patients that tiredness is not a disease, right? Tiredness is not a disease.
Symptom.
Tiredness is a sign of body saying that I don't have reserves. I don't want you to carry on doing so much work. Please get tired so you don't keep on using my reserves, right? So it's a sign body saying slow down. And you can't lose so much weight and not feel tired.
Yeah, that's just not going to happen.
That's not going to happen. So I think, again, we need to draw a line where are you actually doing it for health benefit or are you doing it for aesthetics?
Great. Anything else you want to?
I just wanted Dr. Asha to also sort of shine some light on maintenance doses. So now we've got lots of patients who've reached their target weight. How should these patients be managed? What dose should they be on for life? Or can they come off it?
They can come off it. So when I start someone on these injections, I tell them that you have to commit for 2 years. Okay. Anyone who's giving these injections for a few months is actually confusing people and confusing your internal system because it's a hormonal treatment. You can't do zigzag with hormones. You need to take it for at least 2 years. You're going to get benefit from day one and you might lose weight in next 3 to 6 months, but to change the pathways in your brain, to develop a habit that will stay with you, that requires 2 years. If you can't do it 2 years, at least do a year. And those who are willing to continue and want to continue, there's no harm in continuing them. Of course, then you have to find a dose where you don't carry on losing too much weight. I will not recommend losing more than 30% of the body weight. Because then they're going to start feeling muscle loss and symptoms. So you can find a dose that works for them, maybe half or quarter of the dose. You can do micro dosing. But the people who have developed really good habits like intermittent fasting, low carbohydrate diet, and they can rely on their healthy habits, they can come off it. And I have patients who have stopped it and they are 2 years post stopping the drug and they are maintaining the weight.
I think that's how the drugs were designed to work alongside, your lifestyle changes, how you continue to do resistance training, how you continue
It just gives you a second chance.
Second chance,
It's like, let's start
You're
from...
supposed to rewire your brain.
Yeah.
And then you continue doing those things.
Yeah.
But yeah.
Dr. Nader, you are a consultant gastroenterologist and hepatologist, but you also run the Dr. Hair Loss Clinic at House of Health. So this is a brand that you run. Of course, there's a conflict of interest and you think it's the best because, you're the owner and creator of this amazing brand. But tell us a little bit about your patients, the patients that come to you who are on these medications and having hair loss. What sort of advice do you give them?
I think hair loss is a very common side effect from weight loss medications. Now, it's not particularly a direct effect of these medications, but the fact that you're losing weight very quickly. So you're in a state of shock. Your body's trying to reserve the nutrients for more important things, and hair is trivial for the body. So it will try and maintain those nutrients, sending them to the right organs. So in that case, what tends to happen is women or men, they describe that their hair has just started coming off. So once they do this, they see hair is coming off. This is shock hair loss, and we call it delusion effluvium, which is stress-related hair loss. Again, commonly seen with other kinds of stresses, whether
We have
it's
seen it always with diseases,
Yes.
any disease. It's an,
Absolutely.
any hospital admission. I tell my patients that, have you ever seen someone coming out of a hospital with a good hair?
Yeah, absolutely. ITU admission, whether it's death of a
C-sections.
relative, C-section, death of a relative, even postpartum, even as you've delivered, the drop in hormones, again, they suffer from it. But now we have evidence that there are treatments that may work for this. Now, obviously, supplementation is absolutely a must. Good diet. Again, stopping the rapid weight loss, but then regenerative techniques like PRP certainly helps because it rejuvenates and stops that shock hair loss. So definitely PRP is something we've tried and helped. And also looking at nutritional optimization. They may be low in iron or B12 or folic acid. So make sure that they're optimized with their nutrients. All of these things together, I think, can help with Mounjaro-related or GLP-1 related hair loss.
Fantastic. And what about medicinal products, topical products that...
Yeah, absolutely. I mean, we know that minoxidil has the highest amount of evidence when it comes to hair loss. Obviously, it's not been studied in this particular setting. We have not really gone that. However, I've been told that big pharmaceutical companies are now coming in with an additional supplement that you'll be taking alongside these weight loss medications to prevent hair loss. But again, minoxidil can help. Absolutely. There's no question about that. Increases your blood flow. So anything that really can, stop that shock that your scalp and your hair is experiencing will definitely help with stopping hair loss to start with, and then hopefully getting something back. But the other thing is, you have to remember, delusion effluvium is a temporary thing.
Yeah.
You will get
Yeah.
your hair back.
You
Okay.
will, but it's a slow process.
Slow process.
It takes 3 to 6 months. So, when obviously people, especially they want to lose weight to look good, and they say, oh, I'm not even looking good because I've lost all my hair.
Yeah.
And then
My
you tell
face
them,
is sunk.
Yeah, and then
Yeah.
you tell them that you have to wait 6 months now. So they're not going to like it. So as you said, that human brain does not prioritize hair. The brain does not care how you look. Because every brain cares that you're alive and you're safe. So it's going to, when you will not give your body what they need to build reserves, it's going to make you tired. It's going to stop giving it to your hair, skin, and nail. So just to conserve energy. So you can supplement it. Anyone on these injections, they must take supplements.
Great. Thank you very much. That was lovely. That's I really found that podcast very informative. We didn't go into the biological mechanisms of these medications because I know there's lots of podcasts on the internet.
I want to add one thing,
Sure.
which my patients always say, I'm still feeling hungry. And I think, I must have said it 1,000 times now, this is not a hunger suppressant injection. It's a satiety hormone. It's a slight difference, right? So you will feel hungry. When you wake up, you're going to have hunger pang, which is okay. But you can feel full with a very small amount of food. So eat very small portion and wait for it to kick in. And because of the satiety hormone, you're not going to feel hungry for many hours after that. And people confuse that with a hunger suppressant. It's not a hunger suppressant hormone. I don't see hunger pang as a very bad sign. That it just body is saying, by the way, stomach is empty. If you give me food, I will digest it.
Yeah.
It does not necessarily mean you have to eat or you'll die. You know, we can learn to just accept that and delay that.
100%.
Because that's what training is about. You say, yeah, I got a hunger pang, I'll eat in 2-3 hours. You delay that. I'm a big fan of intermittent fasting. So you're not eating all the time. So the body is not always in a storing form. When you give longer fasting gap, the body will say, well, I have to use the stores.
Yeah. No, there's a lot of evidence around intermittent fasting. Guys, I hope you found this video podcast helpful. We will see you with another episode with another guest. Thank you for tuning in. If you like this podcast, please like, subscribe, and share with your colleagues and friends. Thank you.